I will focus quite specifically on near-infrared spectroscopy monitoring. Now, what I hope to do in this talk is just briefly outline or give you an overview of the technique as it's applied and some of its limitations and pros and cons. And then I will focus more specifically on cerebrovascular autoregulation. I will present some pilot results that we've done, or pilot studies we've done at Liverpool ICU that we're hoping obviously to extend within this network in Sydney. And it would be fantastic if we could go beyond Sydney even, but we'll see. And I hope to finish by just giving you some examples of what we might expect coming next. Now, very shortly then, in principle, in the near-infrared spectrum, there's several molecules or chromophores that are very interesting when it comes to assessing oxygenation. Typically, we'll look at the oxy and deoxyhemoglobin states, but within this spectrum, there's a lot of other potential molecules of interest, for example, including cytochrome C oxidase, which is truly the terminal point of the respiratory cascade. The problem is that its concentration is so low, so it's difficult to measure. But with the technique involving, we might have one day where we can actually see how is oxygen dealt with at a mitochondrial level even. Now, the important thing to remember just from the technical aspects is that as you emit light and receive light using optodes that are attached to the, is this one working? Not sure it is. Attached to the skin there. Most modern optodes will use multiple wavelengths, and they'll be using multiple distances between the transmitting and the receiving ends, and that's just to be able to use different algorithms to separate light that has gone more or less far through the tissues. Near-infrared light quite easily penetrates skin, subcutaneous tissue and bone, and that's excellent, but what we need to know is how much of that light has gone through the brain as well, and how much has just gone through the subcutaneous tissues. By using multiple wavelengths and multiple distances between the optodes, or diodes I should say, you're actually able to subtract the extracranial proportion from the cranial proportion. Now, it doesn't matter really how you do that. It's always important to know that every monitor will have its specific algorithm to do so. So if you're thinking about buying the Foresight and comparing the results with the Equinox or the Invoice, just to mention three of the probably most commonly used NIRS machines, they are going to use different opto designs. They are going to use different algorithms. Some of them are quite proprietary, and they will not even disclose how they calculate those things, and therefore it's incredibly difficult to compare one study with another if they're using different devices. There's also other algorithms like you referred to, Andrew, and Hamamatsu, to mention the fourth, probably most common one. They use a completely different algorithm. Each vendor would, of course, argue that theirs the best. All I want to stress is it's important to realize that you can't really compare one monitor with another if you're looking at absolute values. The STO2, the oxygenation within the tissues, yeah, great. Thanks, Manoj. Truly reflects the balance between supply, oxygen supply and demand. And in that sense, it's a very dynamic variable. The STO2 then obviously will depend on the arterial oxygen saturation. It's dependent on the hematocrit, the diffusivity of oxygen within the brain tissue, obviously the metabolic rate, but most importantly, it's dependent on cerebral blood flow. So out of all those variables that might affect your STO2, thanks very much, that might affect your STO2 result, the cerebral blood flow is the one that's likely to change over a short period of time. And that becomes even more relevant when you're talking about cerebrovascular autoregulation. So just keep in mind that all of those things are impacting on your measurements. It's a dynamic measurement, and if you follow that closely, you'll have a good assessment of cerebrovascular flow. Another important feature of the principle that you need to remember is that spectroscopy as a physical principle relies on you knowing the volume in which you're trying to estimate the concentration of whatever compound you're interested in. We don't know the exact volume in the transluminated brain tissue, and furthermore, we don't know exactly how much of that represents the arterial compartment versus the venous compartment. So all the monitors will have an assumed partition between the arterial and venous components, obviously relevant to the oxy and deoxy hemoglobin states, that probably varies between 30/70 or 25/75. Again, that's a difference between different monitors, but more importantly, they all assume that this partition remains constant during all your measurements, whereas the patient's condition, including changes in blood flow, in metabolic rate, and as I'm sure will become very apparent later on today, changes in temperature or the PaCO2 will obviously impact on how those two compartments are partitioned. So if you change one of those, but your monitor is still assuming it's 30/70, you'll have a spurious result potentially. Finally, it's important to remember, as has already been alluded to, you only measure a fraction of the total brain tissue. Optodes, the way they're clinically applied, typically transluminate an interesting part of the brain, this watershed area between the anterior and the medial cerebral arteries. So although you're probably measuring within a milliliter, a cubic centimeter of brain tissue, it's an area that's quite sensitive to any changes in oxygenation. So within that watershed area, if things are happening there, it's probably an early signal that you should be looking at what's happening in the brain globally. So that might not actually be a bad place to measure. So just to summarize the technique, it's certainly applicable bedside. It provides continuous measurements with very high temporal resolution. The spatial resolution might not be ideal. It's definitely non-invasive, doesn't require any calibration procedures before you start, and it's relatively operated independent. If you can just learn how to put on the optodes, then that's it. On the flip side, there's no standards really for how to report the end variable, STO2, and it differs depending on your equipment. There's no defined normal range, and it is influenced to some extent by extracranial artifacts. It doesn't matter how you design your optode or how you argue that you're not measuring the extracranial flow or saturation, you will to some extent do so. The normal STO2, if you look at the literature, is reported to be anywhere between 60 and 75%. Just keep in mind that that's got a coefficient of variation of 10%. So that's quite significant if you're only looking at an absolute value. I thought I'll just quickly move through a few studies to put this measurement into context before we do autoregulation and talk about our pilot studies. NIRS has probably been most comprehensively used in patients undergoing bypass surgery. And this is a fairly recent review looking at that in excess of 6,000 patients. Now, out of this review comes, interestingly, there's no definitive evidence to suggest that monitoring STO2 is helpful. And that's a harsh statement, but then you need to remember that when they say it's helpful to prevent stroke in the setting of patients undergoing bypass surgery on extracorporeal circulation. Well, the incidence of the stroke in those studies are anywhere between 1% and 3%. So if you're going to change the outcome for something that's luckily relatively a rare event, then that's expecting a lot from your monitor. There is no consistent use of a threshold, so even if many centers would smack on the optodes, and the anaesthetist and the surgeons would be concerned if it drops below this or that value. That's not particularly helpful. But the trends, like for any monitor really, is much more informative, and a decrease between 13 to 20% signifies a significant decrease in cerebral oxygenation. So wherever you start, if you see that drop, you probably should be concerned. It's also important to remember, even if this is a very large cohort of patients, there's no consistent approach to treating low StO2. As again, you alluded to, Andrew, even if you look at monitors and try and associate them with outcomes, we need to know what treatment did that monitor trigger. And if that's not consistent, we can't expect any consistent results, really. What's interesting, I think, looking at those studies is that regardless of whether the intervention based on the monitor actually changed the outcome, it seems like in almost all those studies, patients who had an StO2 targeted therapy delivered tend to do better in terms of other organ failure. And that's why I believe the brain is an interesting index organ, that if you look after the brain well, the patient is likely to do better anyway. Just briefly touching upon results in TBI patients. Again, there's really no firm evidence to suggest it's routine use. There's variable correlations with other standard measures like ICP and brain tissue oximetry and even jugular venous oximetry. But keep in mind that them in themselves, as Andrew reviewed so nicely, has got quite a lot of variability and poor association with outcomes. So if you combine the two, again, I don't think it's fair to expect that you would have that robust correlation, really. But NIRS monitoring seems to be quite reliable in terms of detecting cerebral edema, as long as it's within the region that you're measuring. This is a fairly recent review where they looked at cerebral oximetry in the setting of cardiac arrest. And the only robust finding really is that the lower your reading is, the less likely you are to achieve return of spontaneous circulation based on the first NIRS or StO2 values they recorded when the patient presented, or what the overall StO2 values were during the resuscitation. So again, there's no robust association, but it tends to suggest that if you're doing poorly, your brain is poorly oxygenated to begin with, well, then you're less likely to have return of your spontaneous circulation. Again, the brain is just an index organ to tell you what might be happening in the whole body. This is a very recent review, just came out a couple of weeks ago, where they looked at non-cardiac patients, so not cardiac arrest, not cardiac surgery, not neurospecific, maybe something that would be interesting to a more broader audience. And I was quite pleased to see that they pointed out that what we really need is not only to look at cerebral oxygenation and cognition, and I should perhaps have mentioned that if you look at NIRS-targeted treatments in cardiac surgery, they are much more useful because the incidence of cognitive dysfunction post-cardiac bypass surgery is probably approaching 50%. So all of a sudden you've got a problem that's large enough to address and that you can measure. And many studies would support that NIRS-targeted therapy actually reduces post-operative cognitive decline. Anyway, so that's fairly well established in the general sort of surgical population as well, but they were asking for studies that would look at cerebral desaturation and post-operative outcome parameters. And therefore, I and my colleagues at Liverpool, we were quite pleased to read that because we recently published this paper where we looked at 80 ASA 3 and 4 patients who were undergoing major non-cardiac surgery with GA. We had their NIRS measurements done on room air, just in the anesthetic room or bay, and then we looked at the response once you provide supplemental O2. The primary outcome was the composite of all-cause mortality and major adverse events within the first 30 days. And the second outcome was the WHO disability assessment schedule. That's what we could do. I'm not at all saying that that's the best way to assess cognition. If we look at the baseline STO2 readings in patients who did not or did develop a postoperative major event, death or major morbidity, it was actually quite different between the two. The way they responded to supplemental oxygen wasn't different, and we couldn't find a difference looking at their cognition assessment postoperatively. Again, they both responded to oxygen. So you might say, well, that's excellent, then we can use this to stratify cardiovascular risk. But look at the box plots and you will see, although it's statistically significant, it's probably not going to be that helpful to tell you that patient will or will not do well. And this is ongoing research we're doing together with the anesthetic department. I think we're up to 160 patients now, and we're still trying to get the numbers to figure out what is the optimal way to apply this method to look for its potential to stratify cardiovascular risk. Moving on to autoregulation then, and again, you've covered that very nicely, Andrew. The only way, I might challenge you though, in terms of where does that autoregulatory range lie for our patients. And every textbook will say it's between 50 and 150 mils of mercury. Well, this is again coming out of the Cambridge group quite recently, and studies would suggest that no, that is not the case. It probably lies within 60 to 85 millimeters of mercury, which is a bit alarming because then we're in that range where we usually target our pressure. It's got significant individual and temporal variability, as I will hopefully show you very soon based on our pilot studies. But you will certainly meet patients who might have a lower threshold for the autoregulation that might be 70, 80 even. And you're thinking 70, 80 is safe. Well, patients who might be hypoperfused or hyperperfused within a range that we would quite happily target with our vasopressors. Now, if you accept that the NIRS measurement reflects cerebral blood flow, then all of a sudden you got a way by which you can compare and correlate blood flow changes with pressure changes. And that's got a few advantages because all of a sudden it doesn't become as relevant what the extracranial contamination might be because you're only looking at changes. Your intracranial perfusion will, to a variable degree, be autoregulated. The extracranial perfusion will not be. So if you can subtract things that happen over time, then all of a sudden you're filtering out a lot of artifacts. So I think this is the way to go when you're using NIRS monitoring. And the tissue oxygenation reactivity index, TOX, is a way to reflect how well does a change in STO2, i.e. cerebral blood flow, relate to a change in mean arterial pressure or your cerebral perfusion pressure. And this correlation coefficient is referred to as TOX, as the reactivity index, and it uses a moving average over 30 seconds. So you measure for 5 minutes, and then you move on and update your figure every 30 seconds. Now, if this correlation coefficient is 0, or it might even be negative, then obviously the flow is not strictly related to your perfusion pressure. So autoregulation is functional. Whereas if you got a positive TOX value, a positive correlation coefficient, the flow is becoming passively related to the perfusion pressure. And just to put those two figures together, this is your textbook display or presentation of autoregulation. This is what the TOX would look like. You would have a TOX that's in the negative area where the autoregulation is working. And you'll have an optimal TOX value at which the prevailing blood pressure, around that pressure, the brain can very, very effectively autoregulate its flow or resistance rather. And you'll have a lower limit and an upper limit above or beyond which you'll risk getting your patients hypoperfused or hyperperfused. I'm just giving you two clinical examples. This is what it might look like when you actually measure it. This is a young female who had a brief dysrhythmic event, quickly defibrillated back to sinus rhythm, admitted to ICU, and within the first hours when we were measuring her autoregulation, she displayed a beautifully normal autoregulatory curve with an optimal tox value around 82.5 millimeters. She made a complete recovery. And in contrast, this is an elderly gentleman who suffered asystole. He had a delayed time to ROSC. He underwent PCI, went into cardiogenic shock, and again, within that first day, his mean tox value was probably be around 0.8, very positive. He's got a very passive, pressure-dependent cerebral blood flow, and he didn't do particularly well. So therefore, we did a pilot study in cardiac arrest patients where we included comatose survivors of cardiac arrest of cardiogenic origin within the first 24 hours of their admission to ICU. We did this over 5 months, so we screened 31 patients and in the end included 23 of them. We also included 28 healthy volunteers just to compare what a normal autoregulation might look like. We measured this correlation, the tox coefficient in those patients for at least 1 hour per day. On median, it was closer to 2.5 hours per day. And we did that for the duration of their ICU admission. I'll show you the results for the first 3 days. The outcome was the survival and or their CPC category followed up at 3 months post-admission to ICU, and that was dichotomized between a good independent recovery versus them being dependent. And I should add that for this study, it was all driven by mortality. All the survivors had a good outcome. So we were hoping that we could have sort of addressed the nuances in cerebral dysfunction. We couldn't, because they either survived and did well, or they died. Well, interestingly, this is now the tox value. So the average autoregulatory capacity on day 1, 2, 3, or cumulatively over days 1, 2, 3, the first 72 hours in ICU, for non-survivors in red and survivors in green. 15 out of those 23 patients died, and their tox value was consistently higher on day 1, 2, 3, or even if you compare them cumulatively over the first 72 hours, compared to the patients who did survive or compared to healthy volunteers. We also looked at the optimal tox value, that is the pressure associated with the best capacity to autoregulate their blood flow, and that's those dots in between. So the optimal tox value, again, was quite different between non-survivors in red and survivors in green, but we couldn't quite find a significant difference between the mean arterial pressure that was associated with that optimal tox value. Having said that, in non-survivors, the tox value was close to 90 millimeters of mercury. And very few of our cardiac arrest patients would be targeted with a MAP pressure of 90 millimeters of mercury. We also wanted to look how is this impacting on patients admitted with septic shock, since septic associated cognitive decline and delirium is quite a significant problem, obviously. The design is very much the same. We had, in the end, 28 patients admitted with severe septic shock using the old criteria. Although for the cardiac arrest patients, similar to the literature, we couldn't find a difference in their STO2 measures. In sepsis, you actually could. So non-survivors, and those were 8 out of the 23, had a significantly lower saturation as measured on day 1 or cumulatively over days 1 to 3 compared to survivors. And equally, their autoregulatory capacity was quite different, and the non-survivors had a positive value throughout, whereas survivors were always able to autoregulate their cerebral circulation to some extent. And importantly, both groups recovered over the first 72 hours, but this difference between survivors and non-survivors remained. So just to give you a brief outlook, what's next? Well, I think if we're using NIRS monitoring, assessing autoregulation is the way to go. This is a few papers looking at NIRS and autoregulation in the cardiac arrest population, and they all suggest that a autoregulatory perfusion pressure targeted therapy is associated with better outcomes. None of them are powered to provide definitive evidence, but they certainly suggest that this is something we should look very closely at. This is a very recent paper looking at the septic population, arguing that if we do measure autoregulatory capacity, maybe that would be the way to target vasopressor support and the mean arterial pressure. We're now looking at big cohorts that, regardless of what pressure, well, within a reasonable range, I guess, with pressure, that's not associated with outcome. Well, it might be that you can't just lump patients into that group or that group, because the brain perfusion will be critically different within the first 72 hours. But this might be a way of individualizing that vasopressor therapy. And this is, again, a very recent review coming out of the Cambridge group, who's probably done more work than anyone else in this area. And this specifically looks at various measures of autoregulation in subarachnoid hemorrhage patients, traumatic brain injury patients. And out of all the measures of cerebral autoregulation, the ones that are based on nerve or NIRS-derived monitoring seem to be performing best in terms of predicting outcome. And that's my final slide. Thank you very much.